Hello, I'm Ronnie Eldridge. Welcome to Eldridge and Company. A physician by training, but an activist by nature, Dr. Jo Ivey Boufford is my hero in the world of healthcare. Someone said she has a resume the size of an encyclopedia, and she said she'll only work with the organizations that she thinks have the capacity to contribute to the public good. So right now she's doing just that as the first full-time woman president of the New York Academy of Medicine. Welcome.
Thank you very much.
So this is a very exciting job for you.
It is a great job for me. It's a fabulous organization. We were founded in 1847 by a group of physicians who were worried about the quality of care in New York.
How things change.
No, I know. But they were very active on really critical issues like maternal mortality and childhood nutrition over the years, marijuana, HIV, all the key issues.
Isn't that interesting?
Yeah, it's terrific.
Yeah.
And they were always very progressive in their stances.
So but this is a new thing for you, a new venue. You do have a resume like an encyclopedia.
Well,
I mean, I can't believe you've done so many things. It's really incredible.
Well, it's all the same trajectory to me.
It is.
It's dealing with underserved populations and sort of social justice.
So what made you think of it? I mean, what was inside of you that directed you into this?
The Academy?
This direction.
Well,
not the Academy. I'm just going to talk about you for a minute.
I think my dad I grew up in the South, and my dad was an activist and was very involved with the Brown versus Board of Education when it was originally decided, and advocated for integrated schools. And I think I picked up a bit of that activism there, and then I did my residency at Montefiore and in the South Bronx at the Martin Luther King Health Center, and it just goes on from that point.
And the whole social medicine was the
the social medicine residency program, and you see the issues that are facing, especially poor people.
I always wonder, though, what starts a person on the path that they're on, and it's increasingly, I think it comes from the environment that they came from.
I think that's right, and the exposure. You get the role models are really important too, which is why we have to do more.
So then you were at one point the head of the hospital corporation for the city.
I was,
An incredible job.
4.5 years. I was there 7.5 years total.
Yeah.
And it was the best job I've ever had. I mean, we had a fabulous team, and we had some money for a few years, and then a couple of years we didn't have. But
city government has a very special characteristic, doesn't it? Because you're right in the middle of the people that you're working with. I mean, there's no distance.
No. I used to laugh and say that, you'd have an initiative, let's say primary care initiative, and then you'd go out to the hospital and you'd say, what do you know about this primary care initiative? It's like, what are you talking about? Or who are you? So it's a good reality test of what you think you're doing.
You went to Washington, so you were first deputy.
Principal deputy for health in the Clinton administration in the first term and a half. And the federal government's interesting because very small changes you can make a lot of difference. But we were hoping for healthcare reform. That's why I went. It didn't happen. We learned a lot of lessons.
Terrible.
Hopefully, some of them are being applied now.
So we'll come back and we'll discuss that later. But now, at the Academy now, you're free really to do almost anything you want to do, it seems to me.
Yeah, pretty much.
So the Academy has different programs, right?
Yeah, our overall theme is urban health, and it sounds obvious to people who live in New York City, but people in policy terms, urban health hasn't gotten that much attention. So within that overall banner headline, we've identified 3 areas we're working in. One is healthy aging, which is trying, and especially here in New York, an age-friendly city, to start with that. The second one is sort of strengthening systems that promote health and prevent disease. So prevention is a big issue. And the third is eliminating disparities. So those are the 3 areas that we're working in, and we have research programs and community engagement and policy advocacy and education.
You also have a connection, though, with worldwide organizations. I mean, and are you still on the board of the World Health Organization?
No, I was when I was in government, but I'm something called the Foreign Secretary for the U.S. Institute of Medicine.
Oh, that's very impressive.
The National Academy of Sciences, so they do a lot of international programs. But we've been for about 8 years, David Vlahoff, who runs our research group, the Center for Urban Epidemiologic Studies, CUNY, started something called the International Society for Urban Health. And it started out as a group of scholars around the world working on urban health issues. And now, we just got back from Nairobi last week. And the first day was mayors and city officials from 17 countries, including Iran and Pakistan and India and Latin America. And we also had a very direct engagement of slum dwellers in Nairobi in the conference, kind of telling their story and bringing their messages. So the focus for international urban development has got to be on the poor and the conditions of the poor.
Right. So when we talk about urban communities, we're so used to talking about the country, our country.
Yeah.
And it's, as you said, I think, what was the figure of the number of people living in urban communities in the future?
Over half the world. Now, as in 2007, we crossed over.
And what makes an urban center, an urban?
Well, it's a good question. I mean, the academics say it's sort of density, complexity, diversity, that the characteristics of it, as opposed to sort of a particular population size. Yeah. But people usually think in terms of, say, a couple of 100,000 people is generally called a city or an urban dwelling of some kind.
So the problems in Nairobi, do they compare to the problems in our poorest neighborhoods in this country?
Well, I think the disparities between rich and poor are the same. The degree of disparity is obviously quite different. So that in a city like New York, I mean, every community has, basic electricity and running water and sanitation and education, access to education, whereas in Nairobi in the slums, a large percentage of people really have no fresh water. They have no ability, no sanitation ability, and kids don't get to go to school.
So do you work then with other parts of the government? I mean, what's going to happen? How do you integrate all these different things?
Yeah, well, we're on our prevention work. We've really been working at federal, state, and local level, and with both nonprofit advocacy groups as well as with the state government and city government here. Yeah. And our sense of it is that to make progress, especially globally, you've got to get a partnership with government, the nonprofit sector, academia, activists. You can't do it by yourself, and government certainly can't do it by itself. So
it's important, though, isn't it, to go out into the communities and talk about it, and not only to educate them so that you can do effective preventive care, but also so in a way they become a pressure group to insist that it happens.
That's exactly right. That's exactly the theory and the practice. And at the Academy now, we sort of set up some of our core values, and one of them is something we call nothing about me without me, which means that you don't sit and plan a program for a group or a community without engaging them and hearing them from the very beginning, not towards the end.
I was thinking about it when they've announced now that they're going to put what they call a public option into the Senate bill.
Yeah.
And they may have an opt-out for states. And I was wondering, I mean, what happens to the people in those states? And don't we need then, if that in fact happens, somebody has to go in and organize people in that state to not let that happen?
Yeah, exactly. I mean, that notion of it, I mean, I think the public option is important on the cost side. I think the more important issue is a path towards universal coverage. I mean, getting a commitment like that from our government is very, very important.
So is there that commitment?
Yeah, I guess there's still about 20 million people that are left out under most of the financial models, and people are working on that issue.
But do they go beyond it and say eventually they want to cover everybody?
Well, I think that's the piece. Yeah. I mean, that's the piece that I'd like to see in the final bill, is that commitment.
And does universal mean mandatory?
Well, I think it has to be. There has to be a mix of government subsidies, but people have to have that obligation eventually, or it can't happen. And I think that only way to level the playing field is to have that happen. But I think your point about the state opt-out is a really important one, because it just creates inequities, and we've got them already in the Medicaid system. And
and what would happen to a political figure that takes away your public option? I mean, I can't believe that there are enough people in states to say we don't want that.
Well, except you see these, people, naive. I mean, Louisiana, Texas, I mean, they've said they don't want any of the stimulus money because they don't like the conditions, and I suppose there's a political climate, but I think the overall public really wants to see, reasonable insurance rates and guarantee about health insurance, some kind of security.
So what are the major issues that we face in urban communities?
I think the disparities in health are really important ones. I mean, if you look at New York, in areas like East Harlem or Bed-Stuy or the South Bronx, you really have unacceptable differences between things like infant mortality among black children, black women, maternal mortality 7 times as much as white women in this city. And we're a rich country, and that shouldn't happen. And it's, I think the city administration is making a lot of effort in many areas, but that's our challenge. We just really have to get everybody. The average should be for everybody, not that there's people so far below.
How does that happen?
Well, it's a combination of issues. I mean, I think if we look at what we're learning a lot more about health is that it's a much more complicated set of influences on people's health than just whether they can get medical care or not. And a lot of what we're doing at the Academy is really looking at neighborhoods and environments and housing and transportation and the availability of education and jobs. So, you know, environments, you can say to people, you need to eat healthy, for example. But if you can't buy if there's no green grocer, no supermarket, or you can't afford, you know, milk, skim milk is more expensive than whole milk. I mean, these are the realities in people's lives. Or you say, let's get some exercise, but the schools don't have recess and there's no safe streets for kids to play in.
And if you have some young kids, it's hard to get to the place that you go for medical care.
That's right. Yeah, that's exactly right.
I know. I find myself saying, oh, I don't really want to go to the doctor. It's such a long trip.
Yeah. And they imagine taking 2 buses or a subway
with a couple of kids and no money.
Yeah, exactly. Exactly.
So what do we do?
Well, I think what we're trying to do by understanding what these factors are is beginning part of the Healthy, for example, the Healthy Cities Project, you know, for age-friendly cities, is to look at environments that allow people, as they age, to stay active and healthy. And the notion is that we want to do that as far upstream as we can. So you do it for kids, you do it for young adults, then the likelihood of them being, you know, well and more active as they get older increases. So it's a sort of all ages program.
But it's also, you have to get a lot of people that affect the people's lives.
That's right.
Educated so they can really be the pressure,
yeah.
right?
And I think what we've learned, I mean, some of our projects have worked with so-called hard-to-reach communities. We've kind of started calling them easy-to-miss communities because it's not their responsibility. I mean, it's ours if we have the notion of trying to equalize the resources available. And a lot of people surprisingly know a lot more about what they need to do, but for issues of availability, I mean, services are open 9 to 5 and they have jobs. Or lack of transportation, or, you know, unsafe housing at night. They're afraid to leave to go out to make it to the health facility. You know, those are all very realistic reasons why they don't do what they, you know, what they know.
So it all has to be coordinated within the city and state. I mean, the housing, people, transportation, and all these different things. They have to, agencies and everything else.
That's right, and that's
who
the
assumes
challenge.
The responsibility for that? The mayor and the governor.
I think what we've seen is the leading elected official has to be the advocate, because ultimately they're the only one that convene all the different, you know, commissioners and different agencies to look at. They have something now called Health in All policy, which basically says you look for the health impact of a decision you're making.
So it's like an environmental impact study.
Yeah, in a way, but for health.
It's interesting.
And we have a broader understanding of health.
Right.
So.
It's so when you compare our city, I know that the Academy of Medicine works with other places, but it is the New York Academy of Medicine, right?
It is, yeah.
So when you compare our city to other cities, where do we rank?
Oh, well, that's so hard. I think you'd have to, I mean, I don't want to be you know, to just back away from your question, but I think you'd have to answer the question based on the service you're talking about. I mean, I think that, you know, New York, when I was in Washington, a lot of the reasons why you couldn't get Medicaid reform or graduate medical education or other things is because New York is an outlier. I mean, in some ways it's a good outlier, and in other ways...
What do you mean by that?
Well, it's much more expensive to do everything here. People, you know, the institutions are, you know, much more... harder to change, shall we say? I mean, I think a lot of what we've seen.
I don't know the terms that go with all these different studies and stuff. But if you're an outlier, does that mean that you stand out from a cohort?
Yeah, that's right.
Is that a good use of terms?
Yeah, absolutely. And what it means is that we could figure out a policy for you know, for Medicaid funding, but we can't figure out how it won't hurt New York or how it won't hurt, you know, Texas or California.
And they're saying that now about health reform.
That's right, exactly. Yeah. So that's what I mean by that. And I think some of it has to do with the institutions are still in the city haven't really moved in the way a lot of, you know, sort of healthcare institutions.
There was a move, wasn't there, to combine different institutions?
And I think that's happened. I mean, health
some
systems
of them have been very successful,
created,
some not.
Some of the mergers have broken apart.
Yeah.
And you know, in fairness to the providers, I mean, we don't have the incentives to make that easy to connect the dots for patients. We don't pay very well for outpatient care or people going to their regular doctor. The connections for referral to specialists and to hospitals aren't well developed, and there's not a lot of financial incentive to make it easier for people to do that because of the way we've kept the financing system in New York.
So when we talk about the major kinds of categories of illness that we want to prevent or help along chronic illnesses, I mean something like diabetes.
Yeah, I mean heart disease, cancer, and obesity are major issues, and what we're doing in those areas is kind of looking upstream and saying, well, what really causes people to have those chronic diseases? And the three big causes are tobacco, exercise, and diet. So you think differently about what your programming is going to be, because we're wanting the excellent medical care that we have in New York for the chronic disease, but we're saying, what can we prevent by getting people eating healthy, making the environment safe for them to exercise, stopping people smoking tobacco, and a lot of the health department interventions in New York City with the regulations on fats and smoking and stuff is an example of using that power to
try to really influence it.
Yeah.
I keep thinking of communist China and the way we used to see it as organized with blocks by block, and that you would have block walking.
Yeah, no, that's right. And there are these things now called walking school buses, where people meet the kids and they walk them to school in groups instead of taking the bus, so that they get the exercise.
Right. We
so
should do
it's
that.
a community organization. New York has a lot of communities. I think there's a real potential for that in New York.
Right. When I worked in the city government, the Young Lords were at their peak. And they liberated a TB X-ray unit truck. We used to have a truck. And actually, they increased the number of X-rays taken like 4 or 5 times what it used to be. Do we have those kind of portable equipment?
Oh yeah, that's absolutely right. I mean, I think the issue is that's the trick, as you say,
bringing it to the people,
and the partnership. I mean, with people who know the community and know how to get people to come out and be involved. And we're doing a lot of work now with the pharmacists, because they're on the front lines in many, many communities that don't have easy access to organized facilities, and they're very responsive to being educators, immunizing people, providing.
It is. It's a major change, it seems to me.
Yeah.
And even the commercials that you see, where the pharmacist helps the person and goes through all these things. What do you do, for instance, if you're talking about pharmacies, when a doctor prescribes a medication, but if they prescribe the larger one, you could cut it in half and have 2 for 1? Does that become a thing that people would suggest?
I think pharmacists are able to do that. Yeah. I mean, normally I think they would have to consult with a physician to change to a generic, because usually physicians, say it's got to be this label. But yeah, things like that, and educating the patient about how to take it more effectively, and also looking to see. I mean, physicians have maybe one course in pharmacology. I say this because I'm a physician, but in medical school, and very often you don't keep up on drug interactions and things like that, or patients move from one doctor to another and they bring a lot of medications with them, and the pharmacists can really help with that.
So you do a program directly with them?
Yeah, we work directly with them. We started out working with them on needle exchange issues and free syringes, and when the legislature changed the rules, and then found that they were really important resources in the community. So we've been involved with them on availability of languages other than English in materials, so people understand what they're getting. We've now involved, especially in immunization, and pharmacists as
That's an expensive project for them, isn't it?
The
language,
yeah, it is. It's been difficult, but they're getting more support, I think, and some of the ones that have really been the most active are the big chains, I think, who do it for all of their affiliates. It's a kind of service they provide. So Duane Reade and Rite Aid and those have been.
And Walgreens is coming around now, too.
Yeah.
It's amazing that we have so many drugstores, pharmacies. I can't believe it. But anyway, you do a lot of work with HIV/AIDS?
Yes, we have, and we still do. Our core research activity, what we call community-based participatory research, it gets the community involved, started out at HIV/AIDS, and really trying to understand, transmission, and why. Now we're sort of working on refinements of why people who still use heroin, what causes them to relapse, what allows the successful ones to get off the drug, how do you, make substitutes like methadone or buprenorphine or other substitutes available to them, and then how do you get availability of those substitute medications into a regular physician's practice, rather than people having to go to a drug program, and the stigma of that. And there's a lot of really, I think, interesting progress in that area.
And was that a topic at the conference?
Substance abuse?
Yeah.
Yeah, it is. It's not as big in the developing world, but I think, if we'd had more people from Central and Eastern Europe, I mean, obviously HIV is huge in Africa. And there was a lot of conversation, but the origins of that are more sexual transmission and mother-to-child transmission rather than drug use.
Do we have that as much here?
Not proportionately.
Not,
no, I think the sexual transmission is a real issue for women who are partners of people that have used substances, and obviously among gay couples or not couples.
So what do you think? I mean, what are the major challenges we're facing here in New York?
Well, I think the major challenge as a matter of health policy is that we don't yet have the incentives for the kind of primary care and prevention that would really allow us to kind of reduce our overall bill, and the incentives to allow some of our great institutions to turn some of their attention to, sort of keeping people healthy as well as treating them when they're sick.
So when you say incentives, who's supposed to provide the incentives?
Oh, I think the government has to, the federal government and the state, and Governor Patterson has shifted funding, from hospitals into primary care areas. But it's a zero-sum game, and for somebody to get funding, you've got to take it away from somebody else, and that's not popular. So part of the excitement, I think, about the healthcare reform is that direct funding for prevention is a very strong feature in all the bills that are still in play. So it's a very exciting time, because not only is it dealing with individual prevention for people, but it's also dealing with community-based prevention. So some of the things we were talking about around housing and availability of healthy foods and walking interventions and tobacco, those will be paid for now in healthcare reform if it makes it through to the end.
And it's also interesting because it would seem to me an incentive to a person is the fear of getting sick or not wanting to get sick. And aren't you amazed when you see people smoking?
But it is an addiction. I mean, and we know that now from the tobacco industry's ploy. So we just have to make sure that people have the opportunity, to have therapies to get off of it. But it's hard. The environment now is so unpleasant that it's just you really have to be.
Incredible phenomena to see that.
Yeah, it's true.
It's when I went to Smoke Enders many years ago, and what they had was a jar, and you put all your butts into this jar, and then at the end of the program, or near the end of the program, you put water in there, and that was so disgusting.
It is.
So you at least saw what was going to happen to you, and that became a great incentive to stop.
That's true.
It's a hard
Well,
thing.
the city health department is showing these horrific
ads
on TV, but
they've too bad.
Well, but they've tested them, and that's the only thing that gets people's attention
Isn't it
at
amazing?
this point. Yeah. But we've been at the smoking thing for over 40 years as a public health professional, so if it takes a little bit more time.
So has the Academy, are you researching the effects, because you don't have a bill yet, it's hard to really analyze what's going to happen around here, is it?
Yeah, we haven't been, again, we're kind of tracking this prevention work and hoping that it stays in, and then hopefully we'll be in a position to really help.
Is there effective prevention work in it?
Yeah, there is. And I think that, tobacco, exercise, and diet, we've got a lot of evidence around the country that for $10 per person per head, in known programs that work in communities, you can save, 7 to 1. New York State could save $7 billion over 2 to 5 years if we could support these community-based prevention programs.
Isn't that amazing?
So, yeah, it is amazing. And, people start to pay attention. I mean, it used to, the sort of notion of prevention is that, well, it takes 10, 15 years, it's not going to be on doing my term of office, or,
of course,
people move from Medicaid to the other.
Absolutely.
But, the fact is we're now seeing really important results in 2 to 5 years. And, that's a gubernatorial time, or Senate term, and others.
So we always have to move politics and all this kind of healthcare and all the advantages to making the world a better place. Always has to include politics, right?
That's right, absolutely. Without political will, it doesn't happen.
Isn't that amazing?
Yeah. Well,
it is.
It's the good news and the bad news, I think. But like you say, you've got to get the community sending the right messages, and the politicians need to listen.
Do people come to you? You have an incredible library.
Yeah, we do.
Tell us about it. Have you seen as many books about these issues that?
Well, the interesting thing about our library is dominantly a history of medicine collection. So we have a lot of interesting work on epidemics back in the, we collect from the 16th century on anything that was published in the United States in medicine and public health. So there's a lot of great stuff, a lot of lessons to be learned.
Have we learned them?
I think sometimes we recreate the wheel, but by and large, I think certainly public health professionals are very well aware of the classic issues. I think in healthcare sometimes we forget that.
So what happened with us with swine flu? It was just that we couldn't get the whatever it was that we need to
Well, you
stop
mean
it?
the original one back in the
Right.
70s or 80s. Yeah, I think the issue there was a real question as to whether there were side effects, and people, got scared off. And now it appears that the virus isn't growing as fast as they thought.
Yeah.
But I think you have to give credit to the mobilization.
It's been an incredible
It has been
mobilization.
amazing,
Yeah.
and people are ready. And as
Absolutely.
soon as the vaccine's
It's better to have
available-
them waiting than not having anybody come and having the vaccine. So
That's exactly right.
much
And you can
better.
see that by the public response. The public really understands this,
Right. So you think we're in the beginning of an era of great change in the healthcare of this country?
I hope so. I mean, I hope we're in the beginning of a much greater appreciation of prevention in the context of the care system, but also the importance of public health and the importance of the communities in which people live, that healthy communities allow people to be healthy, and we have to deal with both.
We've gone through this whole conversation and we haven't mentioned the cost of it.
Yeah.
It's really interesting.
Well, I mean, the cost of care is so dominantly in the hospitals. And if you look at any study of, a group of people who get sick, I mean, only about a third of them actually enter the formal care system. I mean, you take care of yourself, right? Or your friends, take this, or you go to the pharmacy or whatever. And of that group, less than 5% end up in a hospital. And yet all we talk about is hospitals and hospital care. So 95% of healthcare happens either self-administered or in primary care practices, or out, in New York City, you'll see much more in outpatient departments than you'd see in other cities, or in other, rural areas. But we're really off balance. I mean, our investment is on the inpatient side, and we need to invest more on the outpatient side and in the community. And if we can balance that, I think we can really achieve a lot.
Well, Dr. Boufford, we have come to the end of our half hour. I must say that I am very pleased to know that you're out there to try improving the public health of the general population, and I think you're a great advocate.
Well, thanks very much.
And
Thanks for having me on.
You're welcome.
Really.
If there are any people you'd like to hear and topics you'd like us to explore, please let me know. You can write to me at CUNY TV, 365 Fifth Avenue, New York, New York, 10016, or you can go to the website at cuny.tv and click on Contact Us. I look forward to hearing from you.